So I'd like to introduce Christian Huck. He's the full professor of Institut Karolinska, and he's also a research and the coordinator of the OCD group there. And his team with Oskar Fligari and Volen Ivanov, right? They are both psychologists and researchers, and they are going to talk about the OCD program and the Hoarding program that Volen is organizing. So the collaboration started some years ago, in 2010, maybe 2011, and I'm very glad that the partnership is expanding now, and we have new projects. And the last time they went here in 2019, they were big fans of Corinthians, but since yesterday, they are big fans of Palmeiras now. But you have to decide, okay? So you can come. So Oskar is going to talk.
Okay, thank you very much. Thank you for the introduction, Elise, and thank you also to you and Euripides for being such nice host once again. We are enjoying it a lot, and I know you guys say that the weather is very cold here, but coming from Sweden, this is nothing, trust me. This is still pretty nice for us, and we're having a very good time. So, like Elise said, I'm a psychologist by training and now a postdoctoral researcher. I work a lot with our internet-delivered treatments that we're using quite extensively in Sweden by now. And one treatment in particular is for OCD, or obsessive compulsive disorder. And today I just want to show you a little bit about the development of the program and where we are right now and where we might be going in the future. So the treatment, we call it OCD-NET. It's a digital treatment for OCD. And so since the development, we have evaluated this treatment now in multiple randomized clinical trials. We also evaluate the side effects or adverse events, and there are very few. Most patients are very satisfied with the treatment. So in terms of adverse events, typical for these types of treatments is that patients may feel increased anxiety levels for some time as they start to do their tough exposure tasks during the treatment. They might also feel some symptoms of insomnia and others, but it's generally well tolerated. And so the treatment was originally developed in Sweden in Swedish, and we have translations now into English and of course Portuguese from the studies here. We are also doing some evaluations now in Germany, so we have a German translation as well, and some additional translations are in the works. So far the results have been very positive regardless of the language as well. We have the English evaluations have been conducted in the United Kingdom and also the United States. And so far from the initial project here, we have seen some encouraging results. And so the main thing that we do is, of course, to evaluate the effect on symptoms, as you are well aware. But we're also looking into some other aspects as well. So one thing is health economic data. So as you might imagine, comparing this internet treatment to a more intensive treatment in the hospital, you can save quite a lot of resources by providing a digital treatment. So we are doing some health economic evaluations, and so far the results are positive as well. So that in the healthcare system, you might save quite a lot of resources by having these digital options. We are also looking into the long-term effects, so up to 2 years after treatment. And we can see that the patients who receive the digital treatment, they have very stable recoveries, and some even continue to improve a little bit over time. So we're happy to see that the effects are sustained. One additional type of analysis that we are often doing is to look at, the predictors of outcomes. So whether there are some groups of individuals that benefit more from the treatment than others. For example, demographic information or clinical information regarding the severity or the type of the disorder or other conditions that interact with OCD. So far, these results are quite unreliable. And if you look at each study, they have different results. So it's not really clear that there is a specific group of patients that benefit a lot and another that benefits a lot less. It's in general effective for most of these groups. And we do some psychometric evaluations as well. So the interviews and the scales that we use, we want to see that they are working properly. So why would you like to do a internet-delivered treatment? Here are some of the reasons that motivate us to do it. So as you are well aware, the recommended treatments are not available for most patients. So antidepressant medication or cognitive behavioral therapy with an expert. For most patients, this is not a realistic treatment option. We have had a lot of discussions with the colleagues here that in Brazil, the expertise is concentrated to large cities like Sao Paulo and universities, but in the smaller cities, there's not a lot of treatment. The same is true in Sweden. Even though Sweden is a smaller country, there are quite large distances between the cities, and outside the university areas, there's not a lot of expertise. So as a consequence of this, very few patients actually receive CBT. So in some surveys, this is as low as 10 to 17%. And of course, in areas that are far away, so in Sweden, that would be the north of Sweden, that's the distances are really large and it would take hours to go to the nearest clinic. These areas are very underserved. And there might be a lot of costs also for the patients, such as having to go by car to the clinic and a lot of time required from the therapist. Yeah. So we have discussed quite a lot about the traffic situation in Sao Paulo, that the distances are large and it might take a long time to go to the clinic. And you can imagine for a lot of patients this is a big issue. And lastly, shame and stigma associated with having a disorder might be another factor that will make patients not receive treatment. They might not be comfortable disclosing their issues to their doctor, for example. So some things about the using the internet to provide treatment make it very attractive as an option. The first is that it is very easily accessible. As long as you have an internet connection on your phone or computer, you can go into the treatment and engage with the materials. So you don't have to sit down with the therapist in their office. And the second aspect is that it's a very low cost because once you have the material in place, you can reuse it as much as you want to. And from the healthcare perspective, it's also the efficiency is also very positive, because when you have few trained psychologists or therapists, they can see more patients. So each therapist can reach up to 4 or 5 times the same in the same time. They can reach 4 to 5 times more patients. So it's a better use of the expertise that you have. And another aspect is what is called therapist drift. So therapist drift can sometimes occur when the therapist go away from the protocol and might have, other suggestions or ideas that are not part of the standard recommended package. And sometimes this can be negative because the patients, in this case, maybe the patients are not receiving exposure in the same amount. They're receiving other interventions. But because the materials are all gathered in a structured way on the platform, there's not that much room for therapists to go away from it. The approach is very standardized. So each patient will then receive a very high quality intervention. So the structure in the digital treatment that we have is divided into 10 different modules. So each module will include some information to the patient and also some worksheets where they can reflect on doing specific tasks and so on. And the patients also receive homework as well. And these 10 modules, the main emphasis is exposure with response prevention. So going into situations that trigger your OCD and practicing to reduce your compulsions. And the structure is also, there's a therapist support included as well. So it looks very much like an email or WhatsApp with messages back and forth within the platform. And the idea is that the therapist is available a few times each day to write and respond to messages. So it's pretty similar to a regular conversation in your messages system. So this is also a positive thing, right? Because you can get feedback. You don't have to wait for the next week to get feedback on your treatment. You can get it the same day or the next day. So the patients can adapt more quickly. So here's a quick history then. So the treatment was, the first study was published in 2011, so a little bit more than 10 years ago. And the first randomized control trial was published in the year after. So the treatment has actually been around for more than 10 years now. And in the following years, there were a lot of more studies, randomized trials, and other reports of the cost effectiveness and the predictors and so on. And then in 2018, we have this treatment available in the Swedish healthcare system. So all patients from all over Sweden can now log on to a website and register interest, and they will have a video assessment with a doctor. And then if they are suitable, they will gain access to the treatment. So they don't have to go to our clinic or anything. They can stay where they are. And in 2018, we also started the international collaboration. So the first one was done in New York. And since then, we have started, of course, many more. The year after, we started here in Sao Paulo. We also did a large evaluation in the United Kingdom. And we started the first studies in Germany as well. So the development that's really ongoing a lot now is this global implementation. And here's just a few highlights of some of the results. Is that, as you can see, the top bars, those are the internet treatments. So the first four, these are results for the OCD internet treatment from different trials. And then the bottom two are face-to-face cognitive behavioral therapy. And the further the bar extends, that's a larger reduction in symptoms. So we can see the face-to-face effect from one of our own trials is very large. That's the longest bar, but the OCDNet treatment is pretty similar in effect in terms of patient improvement. And here's just to show that the effects are continue to they're maintained over time. So the line shows different assessment points, and the last one is 2 years after treatment. You can see for most patients the effects are sustained or even improve a little bit more. And some additional results that we want to show is that the missing data is relatively low. This is, of course, different between the studies, but around 10% missing data after treatment, which we're happy about. For some studies, this is a bit higher, but in general, this is the case. And most patients would recommend the treatment to a friend or would try it again if they had more issues, so it's highly acceptable. And in terms of safety, like I mentioned, the adverse events, the severe adverse events are very uncommon. It's mostly increased levels of anxiety during the beginning of treatment. And in terms of cost effectiveness, this is when you look at the extra resources needed to gain the effects of treatment, and then compared to supportive therapy, which is more a very basic type of therapy, it's around $700 to move one additional patient into remission. And this is a very low cost compared to most medications and other interventions, for example. And like I mentioned, the treatment it started implementation in 2018 and it was fully going by 2019. And it's now the most popular treatment for OCD in our clinic. So most patients receive internet treatments compared to coming to the clinic. And as we all learned during the pandemic, we can see patients over video and telephone, so the patients can stay where they live. So just one interesting thing, since the treatment was implemented before the pandemic, we saw that, so the first line here is the internet treatment, the top line, and then the lower line is face-to-face treatment. So the number of patients in each treatment. We see that it was the most popular treatment already before the pandemic. But it's interesting to see also, so this line, the black line here, shows March 2020 when the pandemic spread. Right after that, we were able to shift a lot of patients onto internet treatment, and so they moved away from the face-to-face treatment when the clinic was, closed and restricted. So the number of patients we saw at the clinic did not change over this time, but we just shifted them to internet treatment. So we were very happy to have this option when the pandemic came, and it was a flexible option for the patients. So they didn't have to stop fully, but they could continue. Here are some additional results from the latest randomized trial, which was published earlier this year. So you see the Y-box scale, which is commonly used by most teams. And then the X-axis shows you the time in treatment after randomization. And these were 3 different treatments. So we had regular treatment at the clinic, face-to-face, internet treatment with therapist support through messages, and lastly, without any therapist support. So just the platform with no therapist involvement at all. And if you look at the very end here, the end of the graph shows you the primary outcome 3 months after treatment. We saw that the group that improved the most was the face-to-face group, which is the circle in this picture. The next one was the internet CBT with the therapist support, which is the orange square. And then the least improvement was seen in the unguided with no therapist support. So the kind of the effects kind of follow the intensity of the intervention. If you come to the clinic, you gain a little bit more benefits compared to internet. But the effects were quite similar, so they're pretty close in terms of the improvement here. So even though the internet treatment with no therapist was the least effective here, you still see that they improve quite a lot from the start of treatment. This is just to show a simple map of the ongoing projects that we have. So of course here in Sao Paulo, in New York and in the United Kingdom, in Germany, and one project has started in Singapore as well, which is the dot far away in Asia. The Singapore treatment is also done in English. So there's a lot of interesting projects ongoing, and so far the results are very positive that in all of these countries, the treatment seems to be working fairly well. So just a quick summary then, that the digital treatment that we have has been well researched for more than 10 years now, with multiple randomized controlled trials. We see that the effects are quite strong, and they are still seen in various countries. It can be easily prescribed by the doctor because you can use it both in primary care and in psychiatry. The system we have in Sweden is fully digital, so you don't have to bring the patient into a specific clinic. You can just add them to the treatment remotely. And it can be scaled up fairly easily because the treatment is highly structured and the platform is already developed, right? So you can add more patients fairly easily. Right, this is just to appreciate the collaboration we have here with your colleagues at the university. In 2019, me and Christian came to work with Alicia and Euripides, and we developed the Portuguese version. And now this year, Christian and I and Bolan as well, we're back and we're developing new projects and using the collaboration to learn a lot from each other, and we appreciate it a lot. If you want to talk to me or discuss anything, you can send an email or contact me on Twitter. And we have a website for the research team that's called rucklab.com if you want to read more about different types of projects and so on. Okay, thank you.
Well, so can you present now, please?
Let's see. Yep.
Great. Thank you very much. And as you said, Oscar, well, this is my first time to Brazil. Actually, you've been here before, but for me, it's been very overwhelming in a very positive way. And of course, not only the country, but also US hosts. So I'm having a great time. Somebody mentioned that we were at the football game yesterday, so we were a bit tired, but I really like talking about hoarding disorder, so I think I'll get some energy up now. And also, this is, although this is my first time here in Brazil, this is a fairly familiar setting for me because I have been organizing the grand rounds at our hospital for the past 3 years in Stockholm. So it feels very nice to be on this side and be the one that's talking and not the one that has to listen. But I hope to make it a pleasant experience for you. So I do work partly as a clinical psychologist in the hospital in Stockholm, where Christian and Oscar work as well. And I'm also a PhD, and I have a research team that is embedded in Christian's larger research group. And I mostly do research on hoarding disorder and clinical research on hoarding disorder. Yuri, you asked me to say some things about skin picking and hair pulling, so I hope that I'll have some time in the end of my talk to mention that as well, because we have clinical experience from that and also a large RCT that is planned for dermatillomania and trichotillomania. But mostly I will talk about hoarding disorder and like a clinical perspective on hoarding disorder. I'm not sure how much you know, but I do believe that hoarding disorder is, of course, prevalent also in Brazil, not only in Sweden, where I come from. And For instance, I heard about the podcast Mulher do Casa Abandonada. So that seems to be, it's always in the media. We hear a lot about hoarding. And of course, pictures like this cause a lot of attention and draw our attention to them, because this is a very kind of eccentric disorder, and the people are also often very eccentric. So please interrupt me while I'm speaking if you feel comfortable, because usually there are not a lot of people who know about this in Sweden, so I have a lot of clinical workshops on hoarding disorder, and they're usually about 6 hours long. And today I had prepared for 20 minutes. So I'll try to broaden that a little bit, but there's a lot in the background that I'm not talking about. So if you feel that something is, I'm not covering something, please ask me, because part of this talk is also to enthusiasm you and believe that this is an interesting disorder to work with and a disorder that can be treated. But unfortunately, if it's not treated, very serious consequences can arise from hoarding disorder. And this is, as I mentioned, frequently in the media. And these are just a few articles that I have found throughout the years. And both are, I think one is from the US and the other is from the UK. And unfortunately, you can't read, but you can, because it's very blurred. But the first one is about a fire that arose or started in a house in the US. And the problems with these fires that arise as a consequence from hoarding disorder is that there's a lot of stuff in the houses that can burn. And it's very difficult for the person inside the house to exit the house, and it's very difficult for the firefighters to get into the house. So unfortunately, these are sometimes lethal fires that cause the death of the people that are inside the fires. And in the second article here, it's a bit old, and the person here is called a collector. And we know now that collecting as a hobby and hoarding disorder are two separate things. But this is maybe 15 years old, so we didn't actually differentiate between these two behaviors back then. Well, anyway, in this instance, the collector was killed by his own hoard. So he was climbing to access something, and then he got like a clutter avalanche on him. So clutter is the stuff that they have in their homes that is in a very kept in a disorganized manner. And the avalanche means that, he was more or less buried alive by all of the stuff. So not to scare you, but I think maybe to make you realize how serious this disorder can be. In the most, of course, extreme instances, it can be a lethal disorder. So we need to find it at an early stage, identify these people, attract them to treatment, motivate them to treatment, and hopefully treat them at least so much that we can avoid these very extreme risks. So I'm not very sure if I'll just run through the DSM-5 criteria for the disorder. This is one of the most recent disorders in the DSM-5, and it has maybe 9 years now in the DSM-5, so it's not super new. But if you're not using it very often, these criteria are a bit new to you. And I know that in Portuguese, or I think that hoarding disorder in Portuguese has the word acumulação in it. And I think that is maybe a bit of a mistake, because accumulating things, to me at least, it means like getting the things, acquiring the things, I'm not sure. But the main symptom of hoarding disorder is actually the difficulty letting go of the stuff. So excessive acquisition is a specifier rather than a core criterion for the disorder. Well, anyhow, so in order to receive this diagnosis, you have to have like persistent, since a long time ago, difficulties letting go of stuff. So it's not just throwing them away, it could be giving them away or selling them. All of this is very difficult for you. And the difficulty is due to a perceived need to save the items and the stress associated with this. So you kind of want to keep your things, you like keeping your things, you don't feel compelled to keep your stuff, like it would be more an OCD that you might have anxiety-provoking thoughts that, well, something bad will happen, something maybe magical will happen if I throw this away, but you actually like your things. And this also has to do, or makes it a bit more difficult to treat, because we say that these are egosyntonic thoughts. You don't feel like there's a distance between you and these thoughts. Like, why am I thinking about keeping all this stuff? This is strange. I don't like them. Rather, you feel like, well, these are my favorite things. I've had them for a very long time. Why would I want to throw them away? This is not my problem. It's somebody else's problem. So they really like their things or see very much usefulness in their stuff. Like, this could be used in the future. So why would I be stupid to throw it away now? And this then results in what I called clutter previously, the accumulation of possessions that congest and clutter the active living area. So I guess the accumulation is in here as well. And of course, as in other disorders, this causes clinically significant distress or impairment. And of course, very often I get the question, well, do these people actually experience distress? And sometimes they do, and sometimes it's more the impairment that is apparent in their lives. They can't do things that they want to do. And this is also a smart thing to use when motivating them to treatment, to kind of talk about the impairment and what they can't do right now, but what they would like to do in the future by throwing things away, rather than just saying you should throw this away. But I'll get back to that soon. And this should then be the hoarding, not attributable to another medical condition or better explained by another mental disorder. I'll mention a few of those soon. And as I mentioned, we have specifiers as well. So these, you don't have to fulfill the specifiers to get the disorder. But we often see that there is excessive acquisition, meaning that the people not only keep their things, but at some point of the disorder have been shopping too much or collecting trash or borrowing things and not giving them back from others, more stuff than they can have place for in their homes. And you also specify the level of insight, which could be good or fair or poor or absent. And this is a disorder often associated with more of a poor or absent insight. So I'm rushing through a lot of things here, so I'm not giving any background on the prevalence of the disorder or the causes of the disorder. If you're very interested, you can of course ask me now, and I'll be happy to mention a few words about that. So I'm kind of diving into the assessment of the disorder. How do we know if it's hoarding disorder? Is it severe enough? Is it caused by something else? Is it depression, and so forth? And at least one very usable or useful questionnaire that is freely available and is not dependent on a specific language is the Clutter Image Rating. And it consists of a series of pictures, 9 pictures for 3 different rooms. So there's a bedroom, a kitchen, and a living room. So you can look at these standardized pictures, and then you can look at the patient's home if you do a home visit, or you can ask them to bring pictures to the clinic, and then you compare them, these two. So for instance, very often we say that, well, hoarding disorder is 4 or above on this scale. So you can use this to determine the level of clutter and assess levels of improvement after treatment and so forth. And it's also easy to communicate with other clinicians or researchers by using this and not only talking about there was a lot of clutter and how much was it. You can say, well, the living room was a 6 and the bedroom was a bit better, it was a 4, but the kitchen was horrible, it was a 9. And you get a very brief picture of that. So I can talk a lot about this picture, but I'll briefly say that if you see a cluttered or encounter a cluttered living space, a room with a lot of stuff or a home with a lot of stuff, hoarding disorder is one potential cause of that cluttered living space. But it could be also to other mental or medical disorders such as OCD, major depressive disorder, psychosis, organic brain disorder, neurocognitive disorders, and autism spectrum disorder. So as I mentioned, maybe the most important differential diagnosis would be, also because we're in a kind of an OCD heavy setting, would be to distinguish it from OCD. So to give you an example, I mentioned the anxiety-provoking thoughts previously, but if I often use like a glass. So when I drink water, I use a glass in these contexts. So if I had OCD and I drank from the glass, maybe I could start thinking, well, what if I leave this here and then somebody takes it and they will get my AIDS disease that I maybe got yesterday when I was at the Palmeiras game. There were so many people, maybe I got AIDS, and now somebody will touch it and they will touch their kids and they will spread AIDS to them. So I will take this and I will steal it with me, and it will be very shameful. But I do not want anybody to get AIDS. So that's why I keep the glass or the bottle. That would be more like a typical OCD thought. But if I rather was thinking, well, this glass or bottle, it's not very special. There are a lot of them around here, but it kind of reminds me of this very special moment when I was at the Sao Paulo University. People were interested in looking at me and listening to me. And I was talking about my favorite subject, hoarding disorder. So if I throw this away, it would be kind of like throwing away the memory of being here and throwing away a part of me. So I will keep it and store it with my other treasured possessions at home. So this is a very common way of thinking when you have hoarding disorder. And the problem for them is that they think this way about a lot of things. And they always make these associations between themselves and the stuff and the memories that they create. So that would be more typical of a hoarding disorder. I will move on now and mention another assessment instrument. Unfortunately, this is only available in English, but I, back in the day, translated it into Swedish, and it was fairly easy. So maybe it could be translated into Portuguese as well. And it's called the Structured Interview for Hoarding Disorder. It's written by colleagues to us at Karolinska, David Matash-Coles, and Lorena Fernandez de la Cruz, and it's a very valuable but quite extensive structured interview that can be used not only to assess the criteria, but also to make a differential diagnosis between OCD and hoarding disorder, autism and hoarding disorder, and so forth. So very useful. Was there a question or just a hand that? No, okay. As Oscar mentioned, we have this website called rooklab.com, and we have the measurements. It's very hard for you to see there, but they're freely available there. So you can download them, at least in English, and look at them and use them for help, hopefully. So if we go into treatment and talk about how these people could be treated, I want to start off by saying telling you the bad news that there is no pharmacotherapy for hoarding disorder. Nothing available. Now, on the other hand, a lot of these people, maybe 75% or 80% of people with hoarding disorder have a comorbid psychiatric disorder. So, of course, if they have depressive symptoms or depression, this can be treated with an SSRI, for example. But if you want to target the hoarding symptoms, there is nothing out there. And there have been no randomized controlled trials for pharmacotherapy for hoarding disorder, unfortunately. On the other hand, the good news is that we have cognitive behavioral therapy, a structured therapy with homework assignments and a structured protocol that we can follow to treat these people. So there have been several RCTs done on cognitive behavior therapy for hoarding disorder. This is an example of group CBT, where one group received group CBT by psychologists and the other group received CBT by peers. So that means people who have themselves had hoarding disorder or have lived with somebody with hoarding disorder. And there is more or less no difference irrespective of who delivers this treatment. Now, one problem is that it's maybe a bit difficult for you to see here, but what this trial says, and a lot of other trials tell us, is that CBT is often not enough for these people. So they're still sick in some way after treatment. So there's one meta-analysis, for example, that shows that Well, if we look at clinically significant change, how many people are more or less without hoarding disorder after treatment, at best it's maybe 1/3 of the patients that receive this CBT treatment. And the effects of the treatment are the lowest or smallest for the clutter. So we can often help them with their difficulties throwing stuff away, but the clutter that they have in their homes is still there even after treatment. So we have to target that in some way. So to give you just a little bit of details about what treatment looks like, I think one important thing to tell you is that mostly we treat hoarding nowadays in a group setting, and almost or most trials that are done nowadays are of group CBT. And I'm not sure why that is the case. Maybe it's because you can target a lot of people more easily than individual therapy. But I think that from the clinical perspective, one reason is that it's much more fun and easy to work with them in a group setting, because when you work with them individually, it becomes more of a fight. It's very easy to become the one that is kind of convincing them to throw the things away, and they're saying, no, 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 don't make me do this. And you can work around that more easily when you're in a group setting. For instance, we've had patients that say, well, I don't have a problem with stuff, I have a problem with space. So if I just get more space, I wouldn't have this problem. So I will probably I have to look for a bigger house, and then I will be able to sort this out, and maybe I shouldn't do the CBT anymore. And then somebody else in the group said, well, okay, I thought like that as well 10 or 15 years ago, and I've moved to bigger and bigger places, and I still fill it up every time. So I don't think that's the solution for your problem. So when you hear that from another person with a hoarding disorder, it's much more easy for you to listen to it and take it to heart than if the young or semi-young psychologist is saying to you, you should throw your things away because you will get evicted very soon. Then you're more of you take a more defensive stance, and then you don't want to throw away the same way. So if you have the possibility to work in a group setting, I think it's much more easy to actually get something done with these people. And usually we work for 16 weeks in a group format. We have like 2.5 year long, it feels like 2.5 years sometimes, but 2.5 hour long sessions when you have them. So it's a quite long treatment, and have in mind that not even this is enough for them. And briefly, what we do is not as much exposure as you would do in a OCD treatment. They don't tolerate exposure the same way. And they also have a lot of like skill deficits. It's very close in a way to the inattentive ADD type, where you have difficulties organizing your stuff, making decisions about your stuff, planning how to throw things away, and also refraining from getting new stuff in the home, being very impulsive when you pass the store, for example. So we teach them skills how to organize and sort their stuff and help them with the decision making. And we do this by asking them to bring things to the clinic. So they come with bags or with boxes, and then we ask them to make the decision, would you like to keep this or throw it away? And we help them with some helpful questions how to do this. And then we keep the things in the clinic and throw it away afterwards, after they have given us permission to do so. And we also work more like a traditional cognitive techniques with behavioral experiments. How would it feel for you to leave this thing in our clinic for the next week? Do you think you could tolerate that? What do you think would happen? And they get new insights by doing this, and also some more traditional Socratic questioning, although we're maybe moving away from that more now. And I guess many of you have met these people, know that motivation is a very huge challenge. So you have to use different motivational techniques and approaches throughout the whole treatment, not only in the beginning. Sometimes when we meet these people in a healthcare setting, they could actually be quite motivated when they start treatment and say, well, finally I would take the chance to do this right now. And then by week 6, they realize this was a lot more difficult than I thought, and they become more depressed. So you have to keep motivating them throughout the treatment, and the motivational module is like in week 10 during this treatment, not in the beginning. And there's also some emotional training, helping them to surf the wave and not get too anxious or tolerate the anxiety when they're throwing things away. So if we get back to the motivation, as I said, the emphasizing the functional gains of letting go of things is maybe the most important thing. That means saying, well, okay, I understand you value your possessions, they mean a lot to you, and they're very nice, but what is the cost you're paying for this right now? What do you think you're losing by keeping these things in your home right now? Is there something that you would like to do that you can't do now? For instance, invite your grandchildren to your home, have them play around in the living room, sit down and have a coffee with a friend. And when you emphasize those things, we've had more success getting them to throw things away rather than telling them to throw the things away. And it's also very helpful to just provide information about hoarding disorder, about treatment, to lower their anxiety and fantasies about what this would mean, and of course their fear of letting go of things, and help them make them trust you as much as possible. And if they've made current progress, in a way, even if it was very small, I had a period when I used to throw things away, but then I got back to my problems. Well, good. For at least a few months or a year, you were actually able to do this. That's great. So let's keep working on that and do it once again, and you keep encouraging that progress throughout the whole treatment. That also enhances motivation. And so these decisions of throwing things away that I mentioned, they're done with the help of boxes. For instance, a donate box, a giveaway box, a maybe box, sell, and a recycle box. Optimally, you would reduce the number of boxes because you don't want to create too many categories, but because that's a problem that they have right now. Everything is very idiosyncratic and should be that. So you do like keep, throw away, and maybe a maybe box that you can work away in time. So this simplifies the process. It does not make the process totally easy for any of you, but it makes it more clear how to work with the stuff. So if I move on to talking a little about the research and the clinical perspective that we have at our program in Stockholm, then it's based on the idea that this is a treatable disorder, but CBT is not efficient enough, so we have to do something more. As I've mentioned, for instance, there's a lot of clutter after treatment, and we ask people to bring stuff into the clinic rather than going to their homes. And we suspect that going to the homes has several benefits. It kind of helps them get doing what they're supposed to do in their home, because they can be very passive in their homes, and they feel more confident in their home if they let us in. And it's where the problem is, and shortly explained. So what we do is we offer them first the group CBT, a little bit shorter, 12 weeks, according to a protocol from David Tolan, a well-known researcher that has done several RCTs, and we have translated it into Swedish. So this is a very evidence-based treatment for 12 weeks. And then we randomize half of the patients to social services, who are the ones who most often encounter these patients. And the social services have, as Christian says, social workers with the patience of angels. So they're very tolerant, and they really work in a very good manner with these people in their homes. Well, anyhow, they then receive 10 home visits by 2 social workers, 1.5 hours per session. So these 2 social workers go into their home, and they focus only on decluttering. They don't talk about past experiences, future plans, having trouble getting food or cooking or shopping. It's just, well, let's take one area at a time and reduce the clutter in your home. So we're comparing that add-on to a wait list for 10 weeks. And we expect that this combined treatment will be a better solution than just giving them the group CBT. And we've enrolled about 25 patients, and it's going fairly well. So we are very hopeful that this will become another treatment avenue that we can use. Yeah, this is what I just mentioned. So this is actually pretty much what I was going to say about hoarding disorder, and I will move on to skin picking and hair pulling. I'm not sure if I should take questions now or if it's jointly with Oscar, and I'm thinking about questions about hoarding disorder that I can answer if somebody wants to know anything.
Maybe take questions now, and then move to another one.
Sure.
I was saying to Hoarding yesterday how much I feel a challenge to treat these patients. When we start our group here, Rosalie is the chief of our OCD group, as you know. When we start our group, hoarding was part of, we understand that hoarding was a subtype of OCD, right? So you work in a dimension, OCD dimension interview, and the hoarding was one of the dimensions. Then with Matthijs Kool, with David, who is not here, another professor at Karolinska, I did my training at MGA at Harvard, and he was there when I was, in fact, he came a little later, he's younger.
Yeah.
But I met him one of my visits, I met first time. Then I think he went to Barcelona or
Yale maybe.
And then or in London, and then became a professor. And David was one of the key people that helped the field change their perspective, showing that hoarding was in fact a different disorder. At least the way we understand, we classify disorders. Hoarding was understood as a different disorder that co-occur frequently with OCD. Probably they share some genes, and in some way they co-occur. But like Colin said, they are different disorders. Although the phenotype can be also, there's a continuum in the phenotype as well. But when dealing with this patient, they are really different than OCD. We don't find that suffering, right, with the symptom. We're not talking about the symptom. It seems to suffer so much. And the insight is always a challenge. Right? And now we're learning the executive function in this patient are a big issue. So when you have a patient like that, making them involved in the treatment is a very difficult. So when a patient call you in your private office, or you always feel a little lazy, and this is like Colin said, like a 2.5 years every hour, right? And but as you see Colin talking, and as you get deeper in the knowledge behind it and try to understand, it becomes more interesting, and you may find interesting treating this patient. I'm sure that Berlin is not 2.5 hours for him for sure. So you become more interested, you get closer and try to understand, and then you create a hope, right? Yeah. You can change. Yeah, exactly. Something different, right? Yeah. So I'm very happy to see the behavioral therapy, the advanced behavioral therapy, and this element, the social worker element, I think may be crucial for treating this patient.
It's the idea of the augmentation trial, right? With visiting sessions, at home sessions with the social worker. So do you have any preliminary feeling if how is it working?
The preliminary feeling is that it's working well. We did a power analysis and to like 8 points on a self-report questionnaire. So it's difficult to say more like the clinical feeling. They are getting significantly better. I think that 10 sessions will not be enough. It would be better maybe 15 to 20 sessions. But for a trial, it's very difficult to make it so long because then you will never be finished. But I do think that what we aimed for, at least in the research, we will accomplish with this. So there will probably be problems still after the home visits, but I think they will be significantly lower than just after CBT. And we're not measuring this, but as I mentioned, like other consequences as eviction and so forth are very difficult, very important to stop them from happening. So I hope that in the long run, these are things that can be achieved as well by reducing the clutter.
We're also going to follow these people a long time to see the stability of the improvement? Yes,
we will. The randomization, the ones that are put on wait list will get the home visits also, but we will follow them for several years. And a bit surprisingly, when you look at some long-term, almost all long-term follow-ups, the effects from CBT are sustained. They're still there, but these people compared to OCD patients, they don't get better after treatment. They remain very passive. They don't do anything. So one thing, of course, that we're thinking of is not only keeping track of them for a long while, but maybe offering some kind of low intensive support over the long course to make them not fall back into their hoarding disorder. So it could be an online treatment, for example, just to remind them.
And the second aspect, just to close it, was that we heard from maybe Caroline Rodriguez about the fire brigade going to these people's homes and making the decluttering. But what I remember from her presentation is that after a few months, they had everything again accumulated at their homes. So perhaps the role of the social worker and the attitude may be felt by the patients as more friendly or more convincing than the fire brigade that goes to the person's home and just...
So it could be a fire brigade, it could be other people that forcefully declutter their homes. And for instance, Randy Frost, who was the godfather of hoarding, he always says that, well, if you remove the clutter, you're not actually removing the problems that cause the clutter. So it's just the superficial thing that you are removing. So it could, in some instances, be a life-saving procedure to forcefully remove the clutter because it will save them from a fire, but it's not a long-term solution for the problems that they have. And we have, when we work with the social workers and social services, we also, not in this trial, but outside the trial, encounter very severe cases where it's very acute and it could be an eviction or a fire. And then we sometimes have to make quite tough decisions, like should this person become homeless, or do we more forcefully remove the stuff? I don't make those decisions. Of course, it's a court, but you have to think about these decisions.
There's a question.
Very nice. Maybe even two?
Hey, I was gonna ask about that thing that you mentioned regarding that support after the end of CBT. So I was actually gonna ask whether you guys had any sort of experience with another form of therapy as an add-on to CBT, because I've never really seen a hoarder patient in a clinical setting, but it just seems to me that this is a manifestation of like an underlying issue regarding their own development as people, right? So I was wondering whether you had any kind of experience of adding some other form of therapy more towards self-development along with CBT.
Yeah, it's a difficult question in a way, because the underlying thing is kind of a philosophical question in a way. Does it have to be underlying, or is it on the side, or is it a part of it? But in any way, I definitely recognize what you are referring to, that there's a lot more going on in these people's lives. So there's one small trial on compassion-focused therapy, because these people can be very, let's say, negative or hate themselves and need to kind of train on their self-compassion. That's one thing. So that would not be an add-on afterwards, but I think it's maybe instead of the CBT. That has been tried, but not in an RCT. One thing that we have been thinking about is adding a personality disorder module or pre-module before treatment to help them with some of the issues that they have before entering CBT. So nothing has been developed, but I do think that it's an important area to research more. And I think it will be, as you're maybe mentioning, more of an add-on than I think you still have to do the boring stuff of like organizing and decluttering, but that could maybe make you more open to receive these treatment. But I'm fairly skeptical of the idea of resolving an issue, an underlying personality issue, and that way finding the answer to their problem. So I don't think talk therapy, if we just do the talk therapy, would be enough for any of these people, actually. Was there another question? I'm happy to take it in that case.
I have a question. I'm sorry, my story is still...
Perfect, yeah.
I have seen one patient with hoarding disorder in my very little experience.
Yeah.
And this patient had morbid schizoid personality disorder.
Yeah.
So I wanted to know if there is a more common personality associated with this. And the second question is, the main concern of the family was they wanted to throw everything away,
Yeah.
but they were afraid that the person was going to have a heart attack or something like this. Is this thing that you do, you just throw everything if the person doesn't want to?
Yeah, a good question. So we kind of touched on it when we talked about this fire brigade going in and throwing things away. So we try to avoid these type of very extreme measures, and they are only done if it's a very serious concern for the person's health and safety. So it wouldn't be a long-term solution, and it's the decisions are made on a case-by-case basis. So how much what's the pros and cons of doing this very severe intrusion into this person's life? So it's definitely not something that we recommend for many people. It's like the last resort that you do for them. And also schizoid personality disorders. Personality disorders are a bit, they go into each other, and you can have several personality disorders. So they're not very well defined, but the clinical experience is that personality disorders, different personality disorders, are extremely common in these people. And maybe and as well, the eccentric types of personality disorders are very prevalent in these people. These are kind of eccentric, strange people that live their lives in a different way than many of us. But there are also a lot of them that are fairly well functioning. They have a job, they have a social life, they go to work, and they don't talk about this problem, and they're well functioning normal people to the person, to the outside person who doesn't know them. So, and a lot of them have autistic traits, autism spectrum disorder, which also brings rigidity to their thoughts and makes them kind of strange, and maybe an overlap with schizoid personality disorder. And also very old people. This is an old person disorder in most cases. And I suspect this was an older person with younger family that was very concerned for him. All right, cool. Yes?
Thank you very much for your talk. I wonder if we should consider hoarding as a spectrum. In this case, you show representing the extreme of a very severe form with this massive cluttering.
Yeah.
There are patients who actually need, sometimes they need lots of space to keep their things, although they are useless, they will never use it anymore.
Yeah.
The patient of mine had to buy another house just to store things he would probably will never use again. So this could be a milder, more acceptable form of hoarding.
Yeah.
But still causes some trouble and distress.
Yeah, I would say two things about that. And the first is that one problem we have with the definition of the disorder is that in part is decided by the economic resources or the space that you have available. So if you're extremely rich and you can buy the one house after another, it will take a long time for you to fulfill the criteria because you'll just be moving things around. You won't have the impairment and distress. Experiences that, and David said this a while ago, they visited somebody in the UK who had a 26-room castle and had managed to fill up every room. So it could be like a question of time. You see the patient today, a lot of 3 apartments, only 2 are full, but you see the patient in 10 years, and then all the 3 apartments are actually full. So you could, in a way, be deceived a little bit by that there is open space, but if you dive into it, you see the difficulties discarding and the impulsivity and the acquisition. But on the other hand, I do believe that it is a dimensional disorder, as most disorders, and Chiara Timpano, that you collaborate with, she has done some taxometric studies showing that this is like a normally distributed disorder. And we don't have that much clinical experience or research experience of the sub-threshold phenotypes of the disorder. What does this look like when it's not hoarding disorder, but when it's like something else? So I think many of us can have difficulties letting go of stuff, and some of us are a bit more disorganized than others. So you will find pretty much anyone is on the spectrum, somewhere on the spectrum. And also another important factor is that this develops over time. So maybe you kind of have less severe symptoms when you're young, and then 30 years later, you have hoarding disorders. So when thinking of prevention, an idea would be to try to identify people who don't have hoarding disorder but are at high risk, and treat them with something that is not the full treatment but more of a low intensity treatment. Just teach them skills of how to organize and let go of stuff so they don't clutter their things. So, but it's still an open question about the distribution and exactly what the phenotypes look around the distribution.
So when you think about hoarding in patients with dementia or cognitive impairment, sometimes you find this sub-threshold phenotype where then when they get demented, then things just
exactly
out of control.
I was wondering if improvement in treatment would not, in terms of new research, improving treatment would not get the advantage of create subcomponents of the disorder. For instance, this executive dysfunction. So I thought, is there any studies using, in addition to developing better executive skills, adding, for instance, stimulants to the treatment? Focus on specific components and see if they...
So maybe you mentioned Carolyn Rodriguez from Stanford. She's also a collaborator on this trial. She started a trial on stimulants for hoarding disorder quite many years ago, and they only treated 5 patients. They were going to do a large RCT, but the problem was that the patients weren't tolerating the stimulants. So they were getting a lot of these, they were complaining about the symptoms, as you probably know if you've met these people. I feel strange, this doesn't feel right, it gets me more stressed. But I do think that they found actually improvements on their hoarding symptoms. So Carolyn often mentions that the stimulants, she mentions this study because she does believe that stimulants do have a role for some patients in some part of the disorder. So it's difficult for me to say like when and for whom, but I wouldn't want to close that door either.
Well, I ask about hoarding, animal cluttering.
Oh, animal hoarding.
Animal hoarding.
I usually have very kind of depressing slides about animal hoarding with people who kept, you find 67 dead animals in the apartment and then 99 animals in the freezer of people. So very, very strange behavior and disorder, and the insight is almost always absent. So they often believe that they rescue the animals from a worse life, and they feel as animal rescuers, but in fact they're treating them very badly. But it's very difficult. There's not a lot of research done on them. They're very reluctant to go into research studies. They don't like society very much, and very afraid, and it's often like a criminal conviction when you encounter these people. So it does seem in many ways to be a different disorder than hoarding disorder.
More severe only.
No, probably that's very difficult to answer, I think, but probably not only more severe, because we don't see very severe hoarding patients that have these tendencies. And nothing is done, and we don't know how to treat them. I have not met one in the clinical practice. So they're out there, but they're not applying for research or treatment. Did I see a hand there? No, just flashbacks. So I'm happy to answer more questions, but I think, would you like to, should I say something about skin picking and hair pulling? Please. Yes, now my anxiety will increase threefold, because this is mainly the subject of my very nice and productive PhD student, Mia Asplund. She's working on a combined treatment for these disorders, because so skin picking and hair pulling, as we can see from these pictures, are quite similar. You pick stuff from your body excessively. In one case, it's the hair, and in the other case, it's the skin. So we have, or she primarily has, developed a combined ACT, acceptance and commitment therapy, like a third wave CBT treatment, enhanced CBT therapy for these people. So I'll say a little bit more about that. And she has treated the disorders together with the same protocol and with good results. And there's a little bit of, there is some more research, especially on the pharmacotherapy done for these disorders than for hoarding disorders. So we have this N-acetylcysteine, which I'm not familiar with because I'm not a physician, that has been tested for both disorders with, I think, quite good results. I suspect that the results are not very sustainable in the long term, so you kind of remit after doing this. And a lot of people don't want to take medication for these disorders. We discussed briefly yesterday that maybe getting treatment at all is not the first thing you think of when you pull your hair or pick your skin. You kind of live with the condition for a long time, and sometimes when it becomes very extreme or interferes with your life, you access or you seek treatment. And then many people want to access behavioral treatments rather than pharmacotherapy.
And just to add, in addition, nobody ever replicated this finding from rats.
All right, so let's be even more suspicious. Yeah, good. So we're maybe thinking the right way to do CBT, hopefully. Now in the first stage we tried the treatment in a group setting, no online components, with okay results. And in the second stage we tested it as an entirely internet delivered therapy. And we included 7 patients with trichotillomania, hair pulling, and 18 patients with skin picking disorder. So this study is under review right now, and I don't remember how many, but some of them had, of course, both disorders, so comorbid disorders. So this is a 10-week program delivered entirely online, and as in our other online treatments, it's based into modules or chapters, and you do like 1 week per module, and there's one therapist supporting you throughout treatment. And this is based on a manual that has been studied before, but not in an internet setting, which is called the ACT Enhanced Behavior Therapy for Trichotillomania by Douglas Woods and Mike Tuhig. So it kind of incorporates or combines traditional habit reversal. So for instance, sitting on your hands instead of picking, and becoming, of course, more aware of your picking and pulling in the first stage, making it more difficult for you to pick and pull. And also some acceptance and commitment therapy, like focusing on your values. What is important for you? Why should you stop pulling and picking, and what should you do instead with your time, and what is important for you in your life? And as far as I understand it, there's a strong emphasis here, not on the habit reversal portion, but on actively exposing yourself to the urge to pick or pull. So you're seeking out situations that trigger this urge, like I want to pull, I want to pick, and then you kind of stop or not to do it. And it's kind of difficult to differentiate between the habit reversal and this. But the main difference, as I mentioned, is that you actively expose yourself and look for these situations and can surf the urge wave, as Mia often says. You surf on the wave of this very strong urge to pick and pull. These are some preliminary results. They seem to be quite good if we look at effect sizes here from pre to post on these 2 different questionnaires. The one in the above questionnaire, the MGHS, is for trichotillomania, and the SPSR is for skin picking. So we do seem to have quite good effects, but so as far as I understand from me, most people do still have these problems even after treatment, but of course to a much lower degree, and the satisfaction with the treatment seems to be very high, and people are happy doing it and feel that this is helpful for them. So of these 10 modules, the mean completion rate was 7.2, so most people do most modules. Participants send around 14 messages to their therapist during these 10 weeks. And a majority, 64%, complete the core components of this treatment. So not a huge dropout there. and around half actually complete all of the 10 modules. So this was, as I mentioned, for 25 patients, and I think we will be recruiting 70 patients starting in September. So this seems to be working fairly well, and I hope that we will expand on it and create an online option, at least for the skin picking population that we're focusing right now, and then maybe the next step for the hair pulling as well. All right, been talking for a long while, but I'm happy to keep speaking.
Any questions about trichotillomania and skin picking? Does your treatment, do you believe that the underlying mechanisms are similar?
Between skin picking and hair pulling? As far as I understand it, I think they're quite similar to each other, yes. The one thing that is that says no, or the thing that makes me think maybe no, is that the hair pullers do seem to be more difficult to treat. They remit more and more often and have the smaller effects from the treatment. So we sometimes also think about kind of reinforcement of doing the treatment, that when you stop picking, you can see that your skin heals much more fastly than when you stop picking from your hair. So you stop picking the skin, then wow, in 2 weeks it's getting much better. Let me keep doing this. While the hair takes a longer time, and then this is so cumbersome, it takes so much time, and then you fall back into the disorder. So that could be also one.
So the urge would be the focus and it's similar.
Yeah.
If someone have some question to ask.
Yes, we thought about finishing. Let's finish here, then I'll go to Oscar.
Perfect.
Any other questions? So before finishing, Roland, so we don't have a group here in our institution focused on skin picking, hair pulling, and hoarding. So this is a real opportunity. And for some of you that came later, our department is sponsoring one resident of third year to go to the Karolinska until February, and then finish the resident, right? And I would take this as a very good opportunity to work with Hoarding and maybe create a collaborative group here, develop some projects together.
That's how I learned about hoarding disorder, visiting clinicians in the US, sitting into the group sessions and watching them work. It was very helpful for me. And
maybe a great opportunity because nobody is studying here. It's in Brazil, and there is no special, no experts. Yeah. So that would be a good opportunity. So keep your eyes open. So maybe now we can ask some questions to Oscar. Oscar, we made some confusions here, but maybe you guys could sit here and me before asking questions to Oscar. Chris, would you like to make a final comment since you were the inspiration for all these projects? Would like to sit there. Sit there. And okay, take the mask out.
Okay, thank you. Well, I think regarding hoarding and what Roland was talking about, I think that 10 years ago or so, we didn't know much. And I also felt quite hopeless feeling this, meeting these patients, that it seems so, really 2.5 year long session feeling, but also what should I do? I mean, what would really help? So I think that doing this development, that you have someone who really is interested, tries to develop this, has the expertise, is a very good idea, and also kind of makes other clinicians feel more comfortable seeing when there is at least someone I can ask. So I think that is a good idea. And I mean, in general, we are very happy to expand our collaboration with you guys, with USP. It has been a pleasure so far. It has actually been a very kind of efficient project as well. So I'm hopeful we can do more in the future.
So just a final comment thinking about Oscar's project and the leadership. One of the things that I feel ashamed when showing São Paulo for you guys, compared to the time I went to Stockholm, is the inequalities. I love this country, but inequalities is the thing I hate the most. And we have only populist governors who don't really have any real propose to change this fact that we have here in Brazil. So I always talk with our residents that are advocates of health. So we're not politicians. Some of us maybe, but most of us don't want to engage in political activities. But what we can do to at least a little bit to change inequality. So one thing I believe is that a project like that, because poverty is associated to mental disorder, and mental disorder and poverty are associated to less income and enhance inequality, right? So I think projects like that is something, a small step, diminishing inequality, right? So what do you think about that?
No, I agree, and also I think the opportunity to give everyone access is much better now, because even if you are not economically very well off, most individuals still have a smartphone because you can do so many things, right? So now that we have these treatments that are available through the phone, it can have a much larger impact compared to having everyone coming to the same hospital and having to travel and, with childcare and getting away from your work, it's very difficult. So I agree that these digital options maybe work the best for those who before had no other option. They couldn't come here to receive treatment, even if they wanted to.
So just for you guys to know, one of the reasons why they are here is a project that we're working together. We will answer from FAPESP in the next 2-3 weeks. And part of the specific subcomponent of this PEAT project is to go to the cities of Indaiatuba, Jaguariúna, and create a platform for internet behavioral therapy for anxiety, depression, insomnia, and also OCD. For the next 5 years, and in 10 years, create a platform to treat all psychiatric disorder, most of that, at least 10, in 10 years, using the CBT for the whole city. So anybody in the city will have access to this approach. And then the idea is to scale at least show the government that is here a project, intervention, a strategic intervention, and can be open to the whole population. That is our aim together. It's a big aim, but yes, that's it.
I have a question for Oscar.
What's your master?
Hi, excellent lectures. Actually, I was thinking, like, when you thought your project about doing the database and everything, have you thought something about to accompany the patients, or also like some filter? How would they access, like anyone, like I don't have OCD, but I could enter it and make the 10 weeks treatment, or like does it have to be linked to a doctor or any other professional health that could give the link or something like this?
Yeah, I think it's a very good comment. So the model right now in Sweden is that it is linked to healthcare. So you do have this assessment with a physician, and they move you into the program. So it's not fully open in this way. I think one benefit of actually seeing someone is that you can, that, okay, I'm doing this treatment right now during a specific period. I'm motivated. I will make time. If it's fully open, maybe you can come back whenever you're not really, focused. But actually in Australia, they have a different structure. So they have a fully open portal as a website. You go there yourself, you respond to some questions, and you get a recommendation. So their system is a little bit different. Like you said, it's anyone can go into the portal and get a recommendation. And then in the next step, they can, if they want to choose to just read themselves, but they can also move into a more structured program if they want to. So I think long term, this might be a good option for many countries to have a screening portal, and then later on move into a more focused treatment. Yeah.
Well, thanks so much for the presentations. Was amazing presentations, and the meeting was very amazing. I hope that next we have more exchanges here. So you're welcome.
Thank you.
Thank you so much.
Thank you.
Sorry, one minute.
Thank you.